The human body operates as a closed, pressurized hydraulic system. When trauma tears a hole in the vascular plumbing, you face a simple physical reality. Keep the blood in the pipes, or the pressure drops, oxygen delivery halts, and cellular disintegration begins. We define this structural failure as hemorrhage, and we categorize it by when it happens. Primary hemorrhage occurs immediately during the traumatic event or surgery. Reactive hemorrhage happens within the first 24 hours, usually because a surgical ligature sloped. Secondary hemorrhage strikes 5 to 14 days post-op, almost always driven by an underlying infection dissolving the clot. External bleeding is obvious, but concealed hemorrhage is the silent killer. A fractured pelvis can hide up to 2 liters of pooled blood. A broken femur can conceal 1.5 liters. Even a fractured tibia or humerus can absorb 750 milliliters each without a single drop hitting the floor. You can memorize these anatomical hiding spots, but knowing where the fluid escapes is useless unless you can precisely measure the systemic impact of that loss on your patient. We measure that systemic impact using 4 classes of hemorrhage. You can think of these classes as a progressive scale of mechanical and physiological failure. Let's look at this table detailing the clinical markers of hemorrhage. Notice how the body compensates through classes 1 and 2 to keep blood pressure normal. The true danger threshold is class 3. Once a patient loses over 1,500 milliliters of blood, the compensatory mechanisms fail and you see an actual drop in systolic blood pressure. Staying on this same table, look at the treatment fluid row. For classes 1 and 2, we replace volume using crystalloids. But the moment you hit that class 3 threshold with dropping pressure, crystalloids are no longer enough. You must introduce whole blood transfusions to restore oxygen carrying capacity. While you replace the fluid, you have to stop the leak. We use direct pressure or tourniquets for visible extremities. For internal cavities, we deploy the FAST scan, a rapid ultrasound sweep over the thorax, abdomen, and pelvis to locate and quantify concealed hemorrhage so the surgical team knows exactly where to cut. Plugging the holes and pumping in fluids will correct a hemorrhage, but if you are too slow, the sustained fluid loss triggers a complete systemic collapse. We call that collapse shock. Shock is frequently mistaken for simple low blood pressure, but the clinical definition is much sharper. It is a state of widespread hypoperfusion that leads directly to reversible and eventually irreversible cellular injury. Hypovolemia limits venous return to the heart. Less blood returning means decreased preload, which throttles cardiac output, ultimately resulting in hypotension. Without oxygenated blood flow, the starved tissues are forced into anaerobic metabolism, producing lactic acid and poisoning the surrounding environment. This flowchart illustrates the body's desperate sympathetic counterattack. Baroreceptors detect the pressure drop and trigger the release of catecholamines. Simultaneously, the kidneys activate the RAS pathway. Together, they force massive peripheral vasoconstriction and aggressively spike the heart rate to keep vital organs perfused. This intense sympathetic response acts as a physiological tourniquet. It buys you time, but it is a ticking clock. The system cannot sustain this overdrive indefinitely without structural collapse. This diagram outlines the 4 categories of shock: hypovolemic, cardiogenic, obstructive, and distributive. Distributive shock is the dangerous outlier. Caused by sepsis or anaphylaxis, the core defect is massive vasodilation. The pipes expand, meaning a normal blood volume can no longer maintain pressure. This comparison table shows how to spot this on the ward. If you have a hypotensive patient, look at the septic shock column. Their skin will be warm, their pulse bounding. That presentation tells you their systemic vascular resistance has bottomed out. Looking at this diagram detailing the stages of shock, we see what happens when you miss those signs. The patient transitions from the compensated stage to the progressive stage. Uncorrected tissue hypoxia drives an intense increase in lactic acid. That rising acidity chemically forces the blood vessels to dilate and damages the endothelium itself. The body's own metabolic waste destroys its ability to maintain pressure, pushing the system past the point of no return. This diagram maps out that point of no return, the irreversible stage. Severe ischemia ravages the intestines, the kidneys enter complete shutdown, and multi-organ dysfunction syndrome takes hold. Once MODS begins, the cellular damage is fatal regardless of how much fluid you pump in. Survival requires aggressive early management. You secure the ABCs, establish wide-bore IV access, and deploy targeted interventions. You push crystalloids and blood for hypovolemia, inotropes to kickstart a failing heart in cardiogenic shock, and powerful pressors to clamp down the dilated vessels in distributive shock. For your exams, lock in these exact triggers. A fractured pelvis hides up to 2 liters of blood. The hallmark of Class 3 hemorrhage is the sudden drop in systolic blood pressure. Distributive shock is identified by warm skin and low systemic vascular resistance, and epinephrine is your absolute drug of choice for anaphylaxis. Trauma bays look chaotic to the untrained eye. But by mapping the precise physiology of fluid loss, anaerobic metabolism, and systemic collapse, you transform that chaos into a predictable algorithm, giving you the exact tools to intercept death.